Today's episode of the Stallside Podcast was brought to you by Rood and Riddle Veterinary Pharmacy.
Hey, Steve, how you doing today?
Peter, I'm really good. I'm feeling great and love being here with you.
Yeah, that's great. You're better looking than my usual co-host.
Oh, no.
So on the show today, we've actually got a couple of our surgeons that are going to talk about a very interesting procedure that is becoming more prevalent on the neck of the horse.
And I think, the neat thing about having Dr. Woodie and Dr. Elzer on today is they're going to be talking about something that is starting to be more and more a big part of our caseload. And, we see a lot of neuro cases, but now we've got one more step or one more piece of information from the CT that we can repair with surgery.
Yeah, previously we've talked about stabilization of the vertebral bodies for compressive issues, but this one's actually, as you say, another step along where you're actually looking to look at the spinal nerves and you're actually looking to improve the pathway of those nerves out of the vertebral column by a procedure called a foraminotomy. And so this is, again, very, very delicate surgery.
It's pretty delicate, and as you might know, I often am in there with them, but my job is mostly to turn the radiograph so that we're all looking at it in the right way. And the other thing is it's really helpful to have somebody who's looked at a lot of necks because the vertebral anatomy can be puzzling at times, particularly if they don't have all of the proper, like if there's an anomaly and, so that C5 suddenly looks like C6 or 6 looks like 5. And so knowing exactly where you are to get the equipment in the right space, it's critical.
Yeah, I think there's another example about how, the collaborative approach that Rood and Riddle takes to its cases.
Absolutely. And the other thing that's really critical, and I think, Peter, you not as old as me, but we've been around a while, and all goes back to first principles. I mean, anatomy and physiology are really, really critical, to helping you, whatever you're going to do, whether it be medical or surgical.
Yeah, saying I've been around a while, Steve, that's sort of like faint praise, but I'm not sort of quite so sure.
Poor Peter, damned by faint praise.
Yeah, you got it every day of my life. So on Stallside today, we have Doctors Elzer and Woodie from Rood and Riddle Equine Hospital talking about the procedure called foraminotomy on the vertebral column of the horse. Dr. Elzer and Dr. Woodie, welcome to Stallside.
Thank you very much. Glad to be here.
Yeah, you've both been on before. Just give us a quick review about your life story to date.
My life story. Well, I've been at Rood and Riddle in some form or another for the past 10 years. I was in Saratoga for a few years, and now I'm down here doing, in part, the spine surgery, which we're here to talk about today.
Great. Brett?
Oh, I've been here almost 23 years now, so got quite a long time. And like Liz, involved with spinal surgery here at the hospital.
23 years, and I don't see in a day too much. So yeah, today's topic, very, very interesting, foraminotomy. And this is something that has evolved pretty quickly over the last year or so. And it's actually a very useful technique. We've previously had a podcast talking about stabilization surgery of vertebrae. But this is actually another technique which has some very unique and impactful indications. So Liz, take it away.
Sure. Well, just backing up, when we talk about the spinal stabilization surgeries, we're typically concerned about compression of the spinal cord itself. But for this surgery, what we're concerned about is compression and, pain and pathology associated with the spinal nerve roots, which come out in between each vertebrae. And there's a bony channel that these nerves exit adjacent to the spinal cord. And if that becomes compressed from bony proliferation, it can cause, pain and other neurological signs. So this surgery is aimed at removing excessive bone that might be pinching those nerves to give horses some relief.
So this sounds like something that's not for every horse. So what indications are there for this surgery? It doesn't sound like a routine sort of procedure that you do. Sounds like the indications are very specific.
Yeah. So, typically we arrive at a diagnosis of a problem with the spinal nerve root after a very thorough lameness and neurologic exam to rule out other causes. 99% of lameness, people like to say, is in the foot, and that's still true. So you should rule out all those other things, rule out the common things, the distal limbs, all the joints there. You also want to rule out any problems with the compression of the spinal cord, like we were talking about, because that would be a different treatment you would need for that. Once you have ruled out any other causes, what you need is a CT or CT scan, 3D imaging of those foramen in order to see if they're compressed and if that could be causing the horse's symptoms. So it's really only horses that you've ruled out all the other possible causes and you've identified an area of narrowing that could be causing the horse's clinical signs.
Yeah, Steve, this looks like it plays to your area, seeing a lot of the neuro horses. So how do you see these horses?
Well, I think, as Dr. Elzer already mentioned, the horses, oftentimes they'll present for maybe an unblockable lameness. That'll be enough. But probably one of the biggest areas that we think, and a lot of owners think, are associated with pain is this behavior change. And they think that the horse is, because of, maybe impingement of those nerve roots, which are mostly motor nerves, but, there is definitely, when there's an arthropathy there, some sensation or abnormal sensation. And so, from a neurologic point of view, occasionally we'll get a subtle ataxia along with it. But for the most part, what we see are the horses that are doing something unique and unusual, often that. And it might be as simple as they just start acting like they can't have the normal range of motion. They don't want to be touched. They're just all sorts of, little things that might be the start.
Yeah, these horses come in, people say, the horse hangs its head to one direction. Yeah. The horse doesn't like turning a certain way. And you're talking about the touch thing. Also, they just can't get the horse to have the carriage correctly for the discipline that they're actually in. And so that's pretty frustrating. Also had one once that actually had sort of like muscle fasciculations running up the side of its neck and it was tilting its head all the time, and it did not look like a lot of fun at all. Yeah. So, the unblockable lameness. So, why would that be an issue, right? So what's the mechanism that these horses appear to have this unblockable lameness, which would drive you to look at the neck?
Well, I think you really have to rule out, like I said, all the other causes, like make sure there's not something, below the neck causing the lameness. Once you've ruled all that out, it's really the pain associated with compression of that spinal nerve root that we think is probably causing it. It could also be sort of a mechanical deficit, like an inability to advance the limb completely normally. But there's most likely a pain component as well. A lot of us have had, pinched nerves in our backs and our necks, and I think we could empathize.
Yeah, that's probably the simplest way to think about it, right? Is that all of a sudden something happens and the horse catches, and somebody's riding it and they sort of say, all of a sudden my horse did this goofy thing. And you go through all the steps that you talk about, as you're right, it's mostly lameness, but then you get these horses that says, well, we just can't block this out, and you've got to look further. So apart from their behavior, is there anything like grossly which may change looking at the neck of the horse? Is there any muscle changes that could occur if these things are chronic enough?
Lots of them will have muscle atrophy. Yeah. So there's very, and in fact, it's been interesting. Since the foraminotomy's been out there, and I know we haven't gotten to that yet, there are two veterinarians who called me, and they told me they can identify the horses that have had the surgery because they get very regional focal wasting of the muscles localized around where they do the foraminotomy. That happened last week. A veterinarian from Wellington, and she was right. She identified horses that I had talked to her about that had, and she showed me a picture of it. And the other thing that, hasn't been brought up is, and a lot of this work was done by Sue Dyson, where they have this intermittent hopping syndrome. And I think that's, if we have time, Liz might even have a video of a horse showing some of that, not necessarily an absolute outright unblockable lameness, but an unusual way of carrying their legs. And then just one slight addition, even though we're talking about framinotomy, we've recently, in fact, this week, had a horse where it looked like the joint capsule, which is, those articular process joints have a joint capsule, had a large outbouching that was pushing the spinal cord over to the side. So it was a synovial cyst, if you will. And that horse also showed some very mild clumsiness in addition to its, the nerve root impingement.
Yeah, I think that really emphasizes the need for advanced imaging in these horses because, like plain lateral radiographs, you're just not going to see these problems. And that's where CT has added a huge value to the diagnostic workup. So what are the sort of things that you would expect to see with some imaging of this condition?
Well, outside of just narrow intervertebral framing, we see a lot of bony proliferation and changes associated with the articular process joints.
Okay. Yeah. So once you've made your mind up, you've actually focally got an area. What's the procedure to actually correct this deficit?
So it's a pretty cool procedure adapted from human techniques. It's called a uniportal technique. So there's one, sort of channel that you put through to the surgical site, which we do very carefully with X-ray and ultrasound guidance, so we're sure to be in the exact right spot. And then you can have your camera, your working instruments all go through the same channel. Dr. Woodie, you can comment too on some of the technique stuff.
Yeah, let's pull up an image of
the instruments
of the instrumentation.
Sure.
We've got a working sleeve, and through that working sleeve, we're going to have our camera and our scope, and with a camera attached to the back of the lens here. We'll also have a light cable for illumination, and we have a port for fluid installation to keep the field of view clear. And through this working sleeve, in addition to the scope, all the instrumentation is going to go through that as well. This is an intra-op photo that you can see with got the camera attached here, got our working sleeve, got a hand on that, and then we've got one of the drilling and burring instruments going through. The nice thing is all the instrumentation can go through that working sleeve without any danger coming to the scope.
Just looking that, I think and the audience will appreciate this. The placement of this instrument is going to be crucial to the success of this procedure. Like a horse is a sizable animal, but you're also dealing with a very sort of small and narrow defined area of a large animal. So how do you, in preparation for the introduction of the instrument, but also during the surgery, make sure that you remain in the optimal place to do the procedure?
Yeah, that's a great question. And it's I think the most important part of the surgery is localizing yourself extremely accurately. It's a small space that you're aiming for, and you're going through a huge amount of muscle to get there. So there's the opportunity to go astray if you're not careful. So we use both X-ray and ultrasound to make sure we're in the right space between the right two vertebrae. And also we use the ultrasound so that we can watch the initial needle we place going exactly to the right place. And in the vicinity is, there's the spinal nerve itself. There is a large artery in the area. There's all kinds of things we don't want to hit. So we're very, very careful not to get into the wrong place.
Right, yeah, it sounds like a lot of skill there. So dimensionally, what sort of distances are you looking to work, and how big is the appropriate surgical window for this procedure?
As far as distance from the skin, we're upwards of 8+ centimeters from the skin to the target. So small movements here equate to very large amount of movement. At the surgical site. But the window is we're talking fairly small.
About quarter size.
Yeah, that you're targeting. And remember, there's a lot of muscle in this area. So when, as Liz said, once we place our guide wire that we're going to feed everything over to get to the site, you don't just immediately see muscle or see the bone. It's covered all in muscle and soft tissue. So we've got to remove that and clear that up so you can actually see the area of bone that's our area of interest.
Yeah, so do you have any images intra-op or any sort of video of this procedure that you can share?
So just to give everybody an image of what we're actually talking about here. So over here on the right side of the screen is a cross-section, like you're slicing a loaf of bread of the spine at the level of one of these foramen. And you can see over here on the right, this area here is very narrow compared to this area here. So this is where the spinal nerve exits. You can see on the left side of this picture that it's very roomy. Over here, it's much more narrow. And there are some measurements here to show you how much bone you would want to remove to open this foramen up. And then we can look here. So this is just a anatomical picture of a horse with all the muscle on, and it just shows you that yellow arrow shows you. So, this would be the horse's mane up here. Here's the windpipe. And then this is the spine here. Spinal cord right there, and then the foramen is just there, just below these two sort of hamburger bun looking bones. That yellow arrow is where your instrumentation goes. So we're going through a whole bunch of muscle, and like the slide says, we're working close proximity to the spinal cord and the vertebral artery, which is right there. So that's why our intraoperative imaging is so important.
Yeah, and I'd encourage anybody that's listening to the podcast to go to the video of this, because that image you just showed really hammers home just how exacting this procedure is to do it to the highest degree.
Yeah. And here's a couple images from in surgery. Here's Dr. Reed making sure we do everything right. Here is our x-ray plate under the horse, so that we can take an x-ray to make sure we're in the right spot. And in this image, I'm hanging on to the ultrasound probe here. Dr. Woodie's passing the needle to the surgical site. I think we have a picture. Oh, and here's a picture of how we localize with the x-rays. We hold some metal instruments that show up on an x-ray over where we think the site is, and then you can see the cross over here on the right. So it tells us X marks the spot, we're in the right place. And then this is, kind of like Greek, unless you do this every day for a living, but this is what the ultrasound looks like. And it just shows you, this is that bone right here. There's the vertebral artery here, right here is the foramen, and then this is the path you want your needle to take. So that's the image we're looking for in surgery. And then, Dr. Woodie, you want to talk about some of this?
Yeah. I'd mentioned earlier about using the radio blader to help cauterize this muscle and soft tissue. So we're going to touch that to it, cauterize the soft tissue, and then we'll use a rongeur to pluck that out and remove it. You can see during this the tissue that's all secondary to the fluid that we're instilling, and that keeps the surgical site field of view clear for us.
So I can see how hemorrhage would be a major problem during this procedure. If they start to bleed, it could make it difficult to continue.
It can be difficult. Yes, absolutely. Yeah, because everything there is vascular.
Yeah.
All right, and then once we've got the soft tissue cleared off, you can see here are some examples of the drills that we use, and these are, pretty small, just a few millimeters across. And then on the right here is a picture of some of this bone that we've cleared away. So up here in the top of this image is what the bone looks like after we've removed some of it. So this is what the inside of a bone looks like. And then down here under all this white fluffy stuff is the intervertebral foramen and the spinal nerve coming out here. I think we have something that shows it a little bit better in a second. And this is a video where we're just cleaning up the edge. So at the top of the screen is the bone. And there's still some soft tissue down below, but we're going to leave that alone so we don't hurt anything we don't need to be touching. And we're just using this, instrument that's guarded on the bottom, but has this cutting surface to allow us to get that very back edge nice and clean. And just under this white band here is, just past that is the spinal canal. So obviously we're very careful and delicate in this spot.
So point out the working sleeve.
Oh yeah, so right here on the left, you can see this is the edge of our working sleeve. And like Dr. Woodie said, we use that a lot. We know that's 1 centimeter across. So if we think, well, we need to remove 1.5 centimeters of a bone from left to right, we judge that. We say, okay, we sort of move our cannula back and forth, and we think, well, we've removed about 1.5 of these cannulas, so we've probably gotten what we need to. And then, of course, we confirm that with a postoperative CT.
And we also use the working sleeve to push the soft tissue and protect it out of the way, so that it provides us a clearer field of view.
So this is a picture of what it looks like before and after surgery. So here on the left side of the screen, this yellow arrow is showing you a pretty narrow foramen, which this horse had some clinical signs associated with this. And then on the right, you can see with this bone removed, we've made a whole bunch of room here for that nerve.
So once you've got the instrument and the portal, you've got everything right in the right location. What is the procedure to actually clean this area to the point where the nerve can actually leave it unpinged? What do you do once you're in there?
Well, we'll start actually with a radioblader, which will provide hemostasis, and we're going to use that on the muscle to basically cauterize that to prevent any hemorrhage, and then we'll use rongeurs to remove that tissue and expose the bone.
You're down. It sounds to me like you're down the end of a really small, narrow window. How do you judge distances? How do you tell the difference between the tissue that you need to remove and the tissue that you need to leave, besides experience?
Well, ideally, once you get down there, you've just got a relatively thin layer of soft tissue in your way, which, as like Dr. Woodie said, you cauterize the little bit of that's in your way and clear it off the surface of the bone. And once you've got the bone exposed, because we have previously very carefully made sure we're at the ventral or bottom part of that bone, then you introduce a bone burr into there, and you can start removing bone and working your way towards the back of that foramen. As you remove bone, you're widening the foramen. So there's sort of 2 stages. There's the soft tissue clearing and then the bone removing stage.
Right.
In addition, to answer your question, as far as knowing dimensions, the instrumentation, we know the diameter and the size of that. So within that field of view, we can tell, our field of view is this amount. So we know, okay, well, this cannula is 1 centimeter, so we've taken out 1 centimeter. We're seeing that. And everything we've measured all the other instruments to know that the dissector, the palpator that we use, that's about 1.5 centimeters, 2 centimeters, so we can utilize those known measurements, because the magnification is there, so makes it look a lot bigger than it really is.
Right.
Yeah.
So this procedure is going to be done under general anesthesia.
Yes.
How long per site does it take? Do you do multiple sites under the one procedure? And if the problem's on both sides of the vertebral column, how do you manage that procedure? Is it multiple episodes of anesthesia, or can you actually reposition the horse during the procedure to actually access both sides?
Well, we typically operate one site per session. Pick the one that's clinically appears to be the biggest offender, and go after that. We've not moved the horse because you're doing them in lateral recumbency. So if we're just doing left side, then obviously the right side's down. So it would take too long to reposition the horse to do the other site. So if it were to require that, then we would need to do that at a later date.
Yeah, I mean, because again, you're going in fairly deep into the horse. It's going to be completely sterile surgical prep, and again, you wouldn't be wanting to move the horse. So recovery, anesthesia, of course, they're in lateral recumbency. stand up. What's sort of their recovery period after this procedure? Because with the degree of invasiveness that you've talked about, getting in about 8 centimetres or so, there's going to be some inflammation and some pain involved in that. How do you manage these horses afterwards, and what's your expected trajectory for the recovery for the horse to get back to sort of normal behaviour and normal sort of function?
So we typically, Dr. Reed might actually be able to comment on this as well, because he's going and seeing these horses out on the farms.
Well, but I think the immediate thing is that, these horses we start manipulating their head and neck one day after surgery, hand walking them within 3 days after surgery, and they're out of the hospital in fairly short time period. So, 3 to 4 days afterwards, they can be out. And in fact, occasionally the owners could take them home earlier and they could do the hand walking there because the manipulation. And then, as far as return to work, some of these horses the soonest would be 12 weeks after the procedure. More likely, you're going to be 16 to 20 weeks. But the good news is, following this surgery, the rehabilitation time is relatively much shorter than if we do the ventral stabilization. Mm-hmm. So it's a really helpful thing. And I think it's critical that they do some manipulation of the head and neck. Number one, it really helps get the horse to get through. If there is any pain associated with it, you can kind of work through that. And most of the time you can do it with just non-steroidals if you need anything, like butyramine, that type of thing, Equiox, those kind of medications. But beyond that, I think then getting that horse back into the position that it's going to be in where the original problem was noted is really, really a helpful thing.
Yeah. And also the surgery site is very small. As far as the surgical incision itself is very small. So yeah, it's not very big, not very big at all.
Okay. Is there any particular type of horse that's going to lend itself to this procedure? I mean, there's various disciplines, various breeds. Do you see that any activities lend the horses to be more likely to require this procedure than others?
I think the majority of horses that we see this in tend to be sport horses, sort of non-racehorse sport horses, if that makes sense. And I think that matches with the time it usually takes for pathology like this to develop, and the specifics of head carriage and, jumping or sudden stops or things like that might exacerbate these kind of issues compared to, say, young racehorses. I did want to circle back to one question you asked, which I'm not sure we totally answered, which is, if you have multiple sites, how do you decide? Mm-hmm. We do, obviously, like Dr. Woodie said, we do only operate one site at a time, and that's just out of consideration for not keeping a horse under anesthesia for too long. And our anesthetists are excellent here, but you never want to treat that. You want to treat that with respect. Mm-hmm. In terms of choosing, if you have a horse that has 3 sites that are abnormal, how do you decide which to operate? And, there are a few different ways to go about it. Number one, maybe one is really severe, and maybe it matches the side that the horse has a problem on. You have an unblockable left front limb lameness, and you've got a really severe problem on a left-sided intervertebral foramen. But it's not always that obvious. So sometimes you could try injecting the intervertebral foramen prior to surgery, and you could do them, try one, see if the horse gets better, or try another one, see if the horse gets better. And you could use that to pick your spot. Mm-hmm. We do that with ultrasound. You can inject steroids kind of like a joint, but we're not injecting the joint. We're just putting the steroid right over the nerve to try and treat it medically, which can help some horses in and of itself. But it also can be a diagnostic that's helpful to help us decide which site to operate. That makes sense.
Yeah, no, that makes perfect sense. Again, it's sort of like a trial run to see what could this procedure do. Yeah. Let's just temporarily medically manage the inflammation and abrasion of the nerve at that point, and if we get a response, great. That's our guy. If not, we need to move on. So again, probably something we should have covered before. You talked about how the horses, what they do. So are there any particular regions of the neck that are more likely to actually have a problem? And you also mentioned age as well and time for this pathology to develop. So if people are having a problem with their horse and they think that this may be something that's going on, what are the sort of age ranges and what are the sort of regions of the neck where you'd be expecting to find these issues?
Well, certainly the low part of the neck, C6-7, is hands down the most common site we see.
Yeah,
but I think it's worth mentioning too that we've done 2-3 on at least 3 occasions. We've had them that high up in the neck, and but I think as Dr. Woodie mentioned, when the horse is, in particular, the ones that are either going with their head in a frame, and if they're in a dressage frame where they've got their face behind the vertical, they put a lot of pressure on C6 through T2. And so getting down those articular process joints low in the neck is quite often where you're going to see the biggest problem. But we've had them up high.
Yeah. And age-wise, I mean, do you think it's going to be age as in age of the horse or length of time doing the discipline?
Both.
Yeah.
But they're mostly teenagers.
Yeah.
Sure.
I'd say a majority of the ones are teenagers.
Okay, radio. That was a very political
But
answer you gave
it
before.
can happen in younger horses too. I mean, it just depends on each horse's specific anatomy and their genetic luck.
Yeah, I suppose that's everybody. We've all played the genetic lottery, haven't we? Yeah. So this sounds like this is almost like a use, wear and tear sort of situation. Do you think there's any traumatic events which could actually lead to this coming, or any sort of degenerative things?
Certainly think it could.
Yeah.
Yeah, I mean, we see OCD, like developmental fragments associated with these sometimes. So, it's plausible that that's part of the pathophysiology.
Okay. And they tend to be sort of like bigger, rapidly, like some of these problems are like large, rapidly growing certain breeds of horses. And so is this, again, in your professional opinion, is it more likely to be a larger, more muscular horse, or is it just indiscriminate? It could be any size, any conformation.
We tend to see it in the large breeds.
Right.
Yeah. The large warm bloods seem to be the most common.
Okay. So what do you think the future of this procedure is? I mean, it's been going for a few years. I mean, it's like anything. Once you start this, people learn a little bit more, they refine it. You've done a number now, and you probably approach these things slightly differently than you did when you first started. So what do you think the progression is going to be in this technique? Where do you think the instrumentation is going to go? And do you think it's going to be more widely applied than it is now once people can actually really see the benefits from these horses? And I'm very sort of impressed with the fact that it's like a very small surgical site, and the recovery compared to some other procedures is actually very quick.
Well, I think first and foremost, getting an accurate diagnosis is really critical. And obviously with the imaging techniques that we have now, before this wasn't possible. Mm-hmm. This isn't a new condition. They've always had it. We just weren't able to diagnose it. And but now with the CT myelograms becoming more and more prevalent across the world, you're seeing more and more of these for making a diagnosis.
Yeah, and I'd have to say, like the imaging, like CT, just with the vertebral compressions that we've dealt with, the addition of CT to the standard contrast myelogram was just revolutionary.
Sure,
and
absolutely.
You start to think about the ability to actually look at the horse in another plane and actually do 3D reconstructions really did put the spotlight on some horses that you couldn't really get to the bottom of, and you really do wonder the lesions that we used to miss that we can find now because the science is just there now.
Right.
What's your verdict, Steve?
Well, I think, number one, I think that this is a procedure that is going to grow in frequency for a lot of reasons. And from a really selfish point of view, if in fact we actually can determine and prove that we can widen the vertebral canal with this approach, that would potentially reduce the number of ventral stabilizations that we have to do. So it might allow us to, because, the number one underlying problem is stenosis in that condition. And if you could widen the canal in some other way without having to do an implant and therefore have all the things that you already mentioned, such as the prolonged recovery time and all that, this would be ideal. So I see this as tip of the iceberg. We're going to be doing it for the problem that we now know is the big issue, but maybe it's going to be beneficial for other things as we go down the road. And the other really critical thing that I think goes along with this is, having this advanced diagnostics gives us such an advantage because some of these horses, the main reason they come to us is bad behavior. And that might just be the bad behavior is due to pain from a problem in their neck. And if we can sort that out and help them, and that's why I like what Dr. Elzer said earlier about potentially you're going to get a little idea of whether you can help them by doing some anti-inflammatory locally before you go to surgery, and that's really critical, particularly since a lot of them do have more than one spot, and we hope that we don't always have to operate 3 or 4 sites.
Yeah, just picking up on that, like Liz said, OCD lesions associated with this. You're sort of mentioning compressive myelopathy associated with this. So you think this is like part of a wider syndrome? Like there's an instability that leads to malformation that leads to the impingement of these nerve roots, or is this just like separate things that can travel in the same horse and they're not related? I mean, I'm pushing it out there, but
no, I think it's all developmental. I think developmental because if you just read the reports that we get back, they almost always describe some osteochondritic or OCD flat out lesion in the articular process joints. And so this is likely a developmental. Now, you have some really good question. What's the role of instability? I don't know the answer to that, but I think if there is some instability, we know that what that has an effect on the canal diameter and on the vertebral body. I don't know what it does to the articular process joints. Really good question, Peter.
Yeah, I come up with them occasionally.
But we do know with stabilization that those articular process joints will atrophy over time.
Yeah.
Perfect point. Yeah, that's a really good thing. Yeah.
It's not fast, but it happens.
And actually, talking about how we're going to be using this procedure going forward, I'll be interested when we start seeing horses that both procedures might be indicated. For example, a horse that might have both instability and foraminal stenosis and clinical signs from both. If you stabilize them, in the long run, you're treating both theoretically because you get that atrophy, that excess bone in the foramen eventually goes away, but it can take years. Whereas if you could do cervical stabilization and then maybe a few weeks later the foraminotomy, you might get those horses' clinical signs resolved quicker.
That's just good.
Yeah.
And I do know some cases that's been done.
Yeah.
Well, again, a very delicate procedure. We're requiring a high degree of precision because there's some very vital structures there that you have to avoid in getting the bone out of the way to free up the nerve.
Yeah.
Wow. Very impressive. So, on stall side this week, I'm co-hosting with my colleague, Dr. Steve Reed. We've had Dr. Liz Elzer and Dr. Brett Woodie talking about foraminotomy in the horse. See you next time.